This is one I've been really interested to see how it's going to work out, and that's Russell Canavan with Eat Me. Everyone, round of applause for Russell, and good luck.
Thank you very much. Okay, so I've asked the rest of the team to come up when they can, because there may be some technical questions. My name is Russell Canavan. I'm a consultant gastroenterologist, Director of Digestive Health at Gold Coast, and an AusPen, which is like a nutrition national group, council member. Our problem is one that's often overlooked in hospitals, which is malnutrition. It's about 40% of inpatients is roughly considered. We know that people with hospital-acquired malnutrition get 21.3 days longer, about $44,176 extra per patient. We also know in several studies that mortality is related to sarcopenia, malnutrition and things. So we think this is a really important issue. We noted there's a lack of consistency of recording, there's intermittent audits, food waste audits, etc. Malnutrition is well studied, loads of solutions, none of which work over many years. Over the weekend, I've been blown away by not one solution, but several solutions that have come forward, and we've actually got a way forward afterwards as well. We took weight, which was originally one of the features, out of it because we felt that we could use 3D imaging later. We've got this deep lab architecture that came through with the convolutional networks. We had a YOLO solution, which we can demonstrate to you in a minute, and we've got the superpixel-based approach as well. There's a lot of TLAs in there, of which I'm going to have to read up on, I'm sure. But luckily, I've got the experts here to answer the questions for you. So for time, I'm going to move on. This is a superpixel-based approach. We took a hospital images, which the dietitians put some dummy meals for us. We managed to locate the plate out of it, clustering with the superpixels, random forest, and we managed to classify the foods so that we can take one away from the other and work out on what comes back to the kitchens automatically. Yeah. Can we play that? And this, if you just concentrate not just on the fact that the bounded boxes can actually identify which food is coming on and off the plates on the demonstration, but look at the size. As the hand covers the meat, the box shrinks. And I'm led to believe that the size of the box is related to the graph of the size of what's on it. So that's potentially, for the future, we can actually also look to using that technique as well. As a team, can we move on, because I'm going to run out of time. I don't want to run out of time.
So you can just click forward if you want.
Is that?
Yeah.
In here. So we've solved 50% of the solution in one weekend with multiple really advanced solutions as far as I can see, and like realistic, real world, every hospital in the world could apply this. We're going to build a rig to look and get the dietitians to do 2,000 or 3,000 as a training model for the network. And as a team, we've kind of agreed that we're all going to carry on working together on this problem. We're going to follow the workflow, automate the workflow, and pump everything through it. And then once we're going to do that, we're going to look at the post-meal images. And then once we've got the ethics, the LREC through, we can look at the RFID tags onto the plate so we know which one went up and which one comes back down and what went missing off the plates. And then Delegate, the health food system that we run all of this on, and there's only two, there's Seaboard and Delegate, is actually going to pump that back into the medical record. So we can actually do end-to-end routine patient care across the world. Wrapped up questions.
So you know Google's doing this already?
Which bit? They're not in our hospital?
No, they're not doing it in a hospital, but brace yourselves, the work's been done. The use of it in this case seems really important. My question is, if hospitals are already giving food to patients, and I agree, obviously there's an epistemic issue, you don't know exactly what a particular patient's been eating, but is the issue likely to be solved through understanding what food they're not eating?
Yeah.
Or is it like a psychological question, or is there something to do with malnutrition that they're not...
Yeah, so there's been loads of research in the areas you can imagine over time. We haven't got a sensing solution that can actually integrate with all the other 700 and something systems that we have in Queensland Health that can actually tell us the information we need. So we have plate waste audits, so we know the total volumes of things, and we have individual studies looking at people going for surgery, people going for discharge, things like that. However, we can't take it to an individual patient level, so we can't do personalised nutrition plans. and we can't link it in with the nasogastric feeds, the intravenous feeds, etc. So this is like an integrated end-to-end solution, but this is the sensing part that allows us to do the rest of what I do, because I'm a nutritionist as a gastro person, so I put people on home PN and tubes and stuff.
So we all know hospital food's terrible. Does this make any difference?
Yes. No. Okay, so the answer is yes, it does. In terms of the plate waste audit, we have a lot more money that we can spend. Also, I can tell our money people, I can convince them that going from cold plating, 4 people, reuse into hot plating, and then onto room service, which is like the pinnacle of the 3 types of service delivery, by purely on the food waste audit.
Okay, so you can get data and then you can change it.
At the moment, I'm trying to change it. I've got no data to support it, apart from plate waste audit, which they kind of look at and go, there's all these problems. You know.
Is this the most efficient way of doing it?
As opposed to getting the nurses. So currently, 99% we don't look. 1% high-risk patient must screening as they come into hospital. We get nurses with nursing time on top of the other 5 things they have to do for that patient at the same time, looking and going, that's about 50% eaten. Next one. So we know that the falls and pressure sores and mortality due to the malnutrition and the expense and length of stay and everything that we're doing, is it the most efficient? Well, if you want to spend nurses' time doing this, and we know that there's a perception problem for nurses because they have to do 10 things at once, and then we tell them off because one of those sometimes doesn't go right. So is this the most efficient way? We'd have to trial that, but it's a hell of a lot better, I think, than what we've got at the moment, in that we can sense before and after and see what's gone between, particularly when we get 3D cameras, so we can look at fluid volume in the cups. Because some things like soups and things you can't do on just an image, 2D image.
Well, thank you very much.